A 20 years old domestic worker and a laborer caught his left hand in a saw. He has a laceration on the left index finger and can't feel the tip of the finger with the open bleeding wound. On examination, the patient has acute open laceration involving the radial aspect of the right index finger. The motor examination was performed. The functional level of specific muscles is determined to assist identifying peripheral nerve injury. Two-point sensory discrimination test is determined by Weber two-point discrimination test using a dull-pointed eye caliper applied in the longitudinal axis of the digit without blanching the skin. In a two-point discrimination, static and dynamic is tested. Simultaneous and monofilament and vibromotor tests are used to assess the status of the nerve. Denervated skin respond differently to stimuli. When the injured hand is placed in water, innervated skin wrinkles and denervated skin does not. This test can be helpful in determining the affected peripheral nerve in hand in unconscious patients. Regarding the type of nerve injuries, they can be divided into neuropraxia, exontemesis, and neurontemesis. Neuropraxia is the mildest form of the nerve injury. This usually involves demyelination within axon disruption and denervation. This type of injury has a relatively short recovery time and full function is expected without innervation, without intervention. Exontemesis occur when axon, myelin, and associated nerve structures are disrupted. The injury often results in a situation in which the traction overcomes the inelastic internal structures but leave behind elastic epineurium intact. When axons are disrupted and the neurium and the rest of the nerve are intact, denervation and regeneration occurs. This is the first stage of the injury that shows an advancing tunnel sign. Because the endoneurium is intact, regeneration should be full and complete recovery with motor and sensory functions regained. Another type of injury occurs when the axon and the endoneurium are damaged and the perineurium and epineurium are intact. This leaves the blood-nerve barrier intact but provides a disorganized bed through which the axon can travel. The nerve regeneration may be slowed due to the infiltration of scar tissue or a small number of axons capable of surviving and regeneration. In advancing tunnel signs, though somewhat slow, should be present. The worst form of closed nerve injuries is when all the structures are damaged except the epineurial covering. This disables the nerve axons and no conduction down the nerve is possible. Surgical intervention is required to restore the function. A tunnel test is present at the level of the injury but does not move distally because the regenerated nerve is kept from advancing by large amount of scar tissue or debris. Neurotemesis is the most severe type. This class of injury is easy to diagnose because it usually involves an open wound with nerve deficit. Surgical repair is recommended for any return to function. The result of surgical repair of digital nerve is inconsistency. Among the factors that could impact an outcome are the amount of direct trauma to the nerves, the length of the nerve that has been traumatized, and the age of the patient. Increased tension on the repair has been shown to also affect the final results. Nerve repair never results in return of full sensibility. However, reasonable protective sensibility of light touch and pinprick may be obtained. Two-point discrimination can approach normal in as many as 1 in 3, that is 33%. For the surgical intervention, after usual draping and prepping of the patient, the skin is marked. The patient is supine and regional anesthesia is administered. If multiple structures need to be repaired, Then general anesthesia is usually should be given using a tourniquet or at the four-level of forearm or the arm. Incision used for this procedure is mid-axial bonal incision because it offers the best extensile exposure of the palm and the fingers. Some surgeons use a Brunner zigzag incision for the exposure as well. Gross exploration is accomplished under loop magnification using tenotomy or other scissors. After initial exploration using a microscope or a high-power magnification, identify the nerve and trim any necrotic or bruised tissue until normal fascicles are found. Then transect the nerve perpendicularly at the mean axis and carefully examine them to ensure that they are healthy and uninjured fascicles are found. Several sequential transactions may be indicated before a final appropriate ending of the repair is possible. It is a systematic approach consisting of a simple suture first being placed on either side of the nerve anteriorly and this followed by another in the midline and then go towards posterior aspect. The intervening epineurium is then sutured. Many surgeons use 9-0, 10-0 nylon or Prolene. If the nerve is under too much tension, the sutures will not hold. If there is a question about tension of the digital nerve, grafting should be considered because holding a digit in flexion to opposed nerve endings often lead to contracture. Closure of the wound is accomplished with simple sutures. A bulky bandage is circumferentially applied on the digit to diminish swelling. A dorsal and a palmar splint may be applied. Post-operatively, the splint is done for 3 weeks, but one sequelae can be stiffness of interphalangeal joint. Absent during tension on the repair and full extension, range of motion exercise can be started at the time of suture removal and earlier depending on the quality of the repair. Hand therapy following nerve repair is individualized and many patients require no specific therapy. If stiffness does develop, supervised hand therapy and dynamic therapy are useful interventions. Restoration of the nerve is followed by measuring the paresthesias radiating distally from the level of the nerve repair when the nerve is percussed, i.e. tunnel side. As regeneration continues, the focus of paresthesia migrates distally. As migration and healing continues, sensibility is noted proximal to tunnel side.